So after looking at basic structure and function of kidneys, looking at the process of filtration, let's look at what happens when the filtrate is passing through the tubules. So basically reabsorption and secretion. Now, tubular reabsorption is highly selective as opposed to the filtration. So kidneys regulate the excretion of solutes independently of one another, a capability that is essential for precise control of the composition of body fluids. So it can choose which ions, for example, to reabsorb more than the others, depending upon what the composition of body fluids is. If you're having, for example, too much sodium in the blood, it will reabsorb less sodium. If you're having little calcium in the blood, it will reabsorb more calcium. So depending upon what is the composition of body fluids, kidneys can fine-tune how much of each substance to be reabsorbed. Make sense? Okay. Now, back to the same beautiful nephron. Filtration. All right. After filtration, most of reabsorption occurs within the proximal tubule. Almost 65% of reabsorption will take place within the proximal tubule. All right, and some secretion will occur here. Some acids, organic acids, which we don't need, they will be actively secreted into the proximal tubule. Reabsorption that occurs here, it's mainly sodium, water, glucose. Glucose is a small molecule. It easily passes the filtration barrier. And you don't want to lose glucose. So all of glucose is immediately reabsorbed here. Okay. Do you know what happens in diabetics? Just a question came to my mind. What happens in diabetics when the blood glucose level is too high? What happens? Do they start passing glucose in the urine? Right. Why? Because the transporters here, which are important for glucose reabsorption, they get saturated. They can reabsorb certain amount of glucose. If too much glucose is passing from the proximal tubule, those transporters get saturated, yes, and glucose starts appearing in the urine. But normally all glucose will be reabsorbed. If amino acids got filtered, they will immediately be reabsorbed. Sodium, potassium, all those electrolytes, calcium, chloride, all will be reabsorbed. 65% of reabsorption will occur over here. In loop of Henle, I'm not going into detail, but the main function, as I was mentioning to you earlier, this part of the tubule is allowing the kidneys to concentrate the urine. Okay, so just ignore this part. Then in the distal tubule, again, there is some reabsorption and some secretion occurring. Same thing is happening in the in the collecting duct. Now 65% occurred over here. The remaining 35 will occur over here. Okay, and actually this part, the last part, it's about 10 to 15% of total reabsorption that occurs here. But this one is much more important than the reabsorption that occurs in the earlier parts of the nephron. The reason for that is this is what we can modify, what we can control by different hormones. This is fixed. Okay, 65% will be reabsorbed here. But this one is variable depending upon different hormones in the system. Okay, so this is variable reabsorption in the distal part of the nephron. Although the magnitude is very little, about 10 to 15% of total reabsorption, but because we can modify it, it makes a big difference. And if you remember, how much filter is produced per day? 180 liters. So even though it is just 10% over here, but little bit of change here can make a big difference in the amount of urine that is produced at the end. Let's look at it from another angle now. So what happens initially? You have reabsorption of sodium, glucose, amino acids, phosphate. There is some secretion of acids in the proximal tubule. All right. This area is involved in concentration of urine and a very complex mechanism. We're not going into that. Okay. Do you remember the counter current mechanism? right? The loop of Henle, the blood vessels going along the loop of Henle. So all that will lead to concentrating of urine. So you can reabsorb a lot of water here. All right, then there is a transporter which is present in the ascending limb of loop of Henle. This is a sodium chloride potassium co-transporter. It requires ATP, it's an active transport. It will reabsorb what? Sodium, chloride, and potassium. Okay. In the distal tubule, we have a sodium chloride transporter, which will reabsorb sodium and chloride. Moving on to the collecting duct. There are two types of cells present there, principal cells and intercalated cells. Now the principal cells mainly reabsorb sodium. They secrete potassium. Okay, and this is under the action of a hormone which is known as aldosterone. Did we mention this before? A little while ago? Remember renin? Angiotensin 1, angiotensin 2 goes and stimulates adrenal cortex, which makes aldosterone. Okay, aldosterone will act here. It will cause sodium reabsorption. When you have sodium moving in, water will follow. So it will reabsorb sodium together with water. When you have aldosterone, what will happen? More sodium is kept in the body, more water is kept in the body, urine volume will decrease. Make sense? Now there is another hormone which is called ADH, anti-diuretic hormone, which causes reabsorption of pure water. So what it does, it punches holes in these cells which are water channels, and it allows water to be reabsorbed. So when you have ADH present in the system, you will conserve more water, urine volume will decrease. Make sense? Okay. Now why did I mention these two over here? Because these two are the sites of action of particular diuretics. You know what are diuretics? These are drugs that we use, and they actually help kidneys produce more urine. For example, people who have hypertension or people who are in heart failure, they are keeping water in the system. You want to get rid of extra water, you give people diuretics. They will produce more urine. Okay. So there are different categories of diuretics. I will only mention the two major ones here. Okay. Okay. Intercalated cells. These cells are involved in acid-base regulation. So we're not touching that part today. So let's come here. Loop diuretics, because they act on the loop of Henle, they're called loop diuretics. They block this transporter. Okay. So when you block this transporter, what is happening? You're not allowing the sodium to be reabsorbed. Sodium stays in the tubule, keeping water with it. So you have more urine produced. Okay. And thiazide diuretic is another commonly used group of diuretics which block this transporter, sodium chloride transporter. So when you block sodium reabsorption, more sodium will pass through the tubules, keeping more water in the tubules. Make sense? But there is one issue with these diuretics. These diuretics, because they are blocking certain transporters of ions, okay, they would have some sort of adverse effects because you're messing up with the natural system there, right? So what happens when you block sodium reabsorption? More sodium is passing here, right? More sodium is passing in the tubules. When more sodium reaches here, you know what is this transporter? It is reabsorbing sodium and secreting potassium. Okay, when more sodium reaches here, through this transporter, sodium is reabsorbed, and as a result, potassium is secreted. So you will end up secreting more potassium. When you secrete more potassium in the urine, what will happen to potassium levels in the blood? They will drop. So there will be hypokalemia. So many of these diuretics can cause hypokalemia, and hypokalemia can be very dangerous. Any fluctuation in potassium levels causes arrhythmias of the heart, if you remember, right? So you have to watch when you're giving diuretics to someone, you have to watch the electrolytes in the blood very carefully. Now, there are many classes of diuretic drugs. They work in a different way. There are drugs which are called osmotic diuretics. Mannitol is one example. So what it does, it is freely filtered at the filtration barrier, and it is not reabsorbed, and it keeps water with it. It's a water loving molecule, freely filtered, not reabsorbed, takes water with it. Okay, so this is an example of osmotic diuretic. It's mannitol. Okay. Again, it can cause hypokalemia, and of course, if you give too high dose, it can cause dehydration, too much diuresis. You have carbonic anhydrase inhibitors. This is an enzyme which is blocked again in proximal tubule, and it blocks the reabsorption of sodium and bicarbonate, and more water will be lost in the urine. Again, hypokalemia. It can cause systemic acidosis, so they are not usually used anymore, in very rare cases. The most commonly used diuretics nowadays are these two: the inhibitors of sodium chloride reabsorption and the aldosterone agonists, or potassium sparing diuretics, the two most commonly used diuretics. Thiazides and furosemide are examples here. Thiazides act at the end of the ascending loop. Remember I showed you in the previous slide? Okay. At the beginning of the distal convoluted tubule, they block sodium chloride reabsorption. Furosemide act on the thick ascending limb of loop of Henle. They block active transport of chloride, sodium, and potassium. I showed you the previous slide. All right. So hypokalemia is one of the common side effects of these diuretics. Then we have, in order to avoid potassium loss, we can use potassium sparing diuretics. Okay. These diuretics are not very strong in their diuretic action, but they don't have hypokalemia as their side effect. They can actually cause, some drugs can actually cause hyperkalemia. All right. So you have to watch for hyperkalemia then. So it will depend which diuretic you give. It will depend on patient's factors. What do you want to achieve? Okay. How much diuresis is required? And depending upon what condition, other conditions patient has, what sort of side effects you can live with and which side effects you can't live with. So you have to make a choice based on patient's factors. There's no single ideal diuretic. It will depend upon multiple factors, which diuretic you choose. Now, towards the last part of today's topic, a little bit about regulation of fluid and electrolyte balance. I'm not going to talk about pH, but a little bit about fluid and electrolyte balance. Water, a lot of water gets filtered, but then it gets reabsorbed. Almost 99.9% of water gets reabsorbed. Okay, and this is passive, so whenever sodium goes, water will follow. All right, 65% reabsorbed in the proximal tubule, 15% in the loop of Henle, 5% in the distal tubule, about 13% in the collecting duct, and this is, which is variable. So ADH can actually cause more reabsorption here. Okay. Now, ADH is a very important hormone when you talk about water reabsorption. Normally, the distal parts of the nephron are impermeable to water. So whatever water is flowing through the distal part of collecting ducts will actually just go out if ADH is not there. But when ADH is there, as I told you earlier, it punches holes in the cell membrane. It inserts water channels. We call them aquaporins, water channels. And because osmolarity around the tubules is high, water comes out. So water is reabsorbed into the blood in the presence of ADH. Now, remember, very small amount is reabsorbed in the distal part, 10 to 12%, 13%. But this small amount is so important, it becomes obvious when you look at clinical conditions due to ADH abnormality. If there is ADH deficiency, which means these patients do not have ADH. If you don't have ADH, what will happen? You can't reabsorb this small amount of water which is passing through the collecting ducts. Okay, these people will have diabetes insipidus, lack of ADH, or there could be ADH, but the kidney, the tubules are not responding to ADH. This is called nephrogenic diabetes insipidus. So either it's a lack of ADH, or ADH is there, but the kidney cells, the tubule cells are not responding to ADH. In both cases, this is known as diabetes insipidus. And these patients will make very large urine volume. Okay, it could be 3 to 4 liters of urine per hour. So their life is actually crippled, right? They can't sit anywhere for half an hour or more because they have to go and empty their bladders. So you can see either, although it's a very small amount in the distal tubules, but this lack of ADH causes huge amounts of urine to be produced. Okay, the second extreme is when you have too much ADH. Too much ADH. Syndrome of inappropriate ADH secretion. And this happens with certain tumors. It could be a tumor of the pituitary, which is making a lot of ADH. It could be lung cancer. There are certain lung cancers which make ADH, too much ADH. When you have too much ADH, what will happen? You reabsorb a large amount of water. So very small amount of urine is produced, very concentrated. So in these people who have SIAD, concentrated urine, very low volume. Patients with diabetes insipidus, large amounts of urine, very dilute.